Good day, everyone. The Society of Cardiovascular Magnetic Resonance is pleased to present this webinar, Stress Perfusion CMR in Patients with Chest Pain, Evidence-Based Summary. My name is Ryan, and I will be the host for today's webinar. Please note that today's call is being recorded, and all participant lines will be muted during the broadcast. Today's presentation will last up to 60 minutes and include a specific question and answer period. However, you can enter a question for us at any time during today's presentation. You may submit a question by typing it into the Q&A box in the lower center of the window. Then be sure to click on the send button located next to the box. And now it is my pleasure to introduce Victor Ferrari, who will introduce today's speakers. Please go ahead, Vic.
Good day, everyone. It's my great pleasure to be here on behalf of SCMR and to introduce today's session. It's a very exciting time for CMR with regard to ischemic heart disease, given that the new joint guidelines just came out, and CMR is represented very well for the first time broadly in the chest pain guidelines. Our speakers today are going to cover two important topics related to these guidelines. And I also want to introduce my co-moderators today, Dr. Balaji Tamarapu and Dr. Matthias Friedrich, both experts in their respective fields and having quite a bit of experience and background in these areas that they can also share with us today. I'd like to introduce our first speaker, Dr. Andrew Arai, who is a close friend and colleague for many decades. Andrew, as many of you know, was a senior investigator at NIH for the majority of his career, spending the past 31 years there, and has recently retired from that position and is now a consultant in the CMR world. Andrew, without further ado, I'd also like to recognize you for the many decades of work you've done both in ischemic heart disease, especially chest pain in the emergency room, which was one of the first seminal publications in this field, and then multiple publications since on myocardial perfusion and assessment of myocardial viability, and many, many other important contributions to the field. So thank you for that, Andrew, and please take it away with your talk, Evidence on the Use of Stress Perfusion CMR, Randomized Trials, and Large Registries. Thank you, Andrew.
Well, thank you for the kind introduction, Vic. My disclosures are listed at the bottom of the slide here. My objectives are to discuss randomized clinical trials and large registry data that support the use of stress perfusion CMR. I also aim to provide some background on how the AHA-ACC guidelines weigh the class between strength and level, which means quality of evidence used to support recommendations. I also want to acknowledge and thank a few people. John Greenwood for all his hard work at the AHA-ACC writing group. I understand that was an arduous task over several years. And to thank Raymond Kwong, John Green, Ike Nagel, and Michael Salerno for advice and leading so many of the landmark studies that got CMR to its current status. There are a couple of things in this overview slide from the guidelines that are worth talking about. First off, it addresses on the left side acute chest pain, and on the right side, stable chest pain. Invasive coronary angiography is appropriately pretty much relegated to acute coronary syndrome and high-risk situations where revascularization seems appropriate. There's a tension throughout the guidelines, anatomic versus functional, and a second tension that CMR is bundled as part of functional imaging. Most of the guidelines don't distinguish CMR from SPECT, for example, or PET. But overall, there's so many good things about this guideline that it's good that SCMR endorsed them. The last point on this slide is that no testing is appropriate. So for low-risk patients in the ER, no urgent testing is needed. It can be deferred for later and reevaluated once a patient follows up. And no testing at the level of imaging, at least, for asymptomatic people. You've all seen these breakdowns of how the ACC and AHA grade strength of recommendations and quality of evidence. I don't want to say a lot here, but to say we now have several class 1 recommendations for CMR. This is a big step forward. And level of evidence is hard to achieve. It's not just that the technique doesn't work, it's what the level of evidence is. To get level of evidence A recommendations, you need to have high quality evidence from more than one randomized controlled trial, or meta-analyses of high quality randomized clinical trials, or one or more randomized clinical trials corroborated by high quality registry data. And I thought this publication out of JAMA is a good way to think that the fact that we're not everything is class 1 level of evidence A is okay. These summarize on the left side the ACC/AHA guidelines, and on the right side the ESC guidelines for all of cardiovascular guidelines from both societies. And you can see for class 1 level of evidence A, only 6.1% of ACC/AHA guidelines hit that level. And for ESC guidelines, it's about 10 percentage points. So anyway, so I think we've done very well. Let's look a little bit at the data that goes into getting recommendations. And so one of the first landmark studies, and one that comes up in the guidelines, is CE-MARC. CE-MARC was a comparison of CMR and SPECT to diagnose coronary heart disease. It was a prospective trial. The panel on the right is the full figure. I've just blown up panel A on the left side, so it's actually legible on everyone's screens. But the bottom line is, any way you broke up the data, CMR is the blue area under the curve, or ROC curve, was higher and better diagnostic performance than SPECT. So that was a large and important study. John Greenwood also has one of the other really landmark studies validating CMR stress perfusion imaging. And this study, CE-MARC-2, was a randomized study. The objective was to test the hypothesis that among patients with suspected coronary heart disease, CMR guided care is superior to UK NICE guidelines directed care and SPECT MPI guided care in reducing unnecessary angiography. So that's really the primary endpoint. Did it reduce the use of unnecessary catheterizations? And this was a big problem because a large fraction of the cath lab studies at that time would show no significant coronary disease and would be an in and out procedure at high cost and some risk. So the design was a multi-center, 3 parallel groups, randomized clinical trial using a pragmatic comparative effectiveness design, 6 UK hospitals, over 1,200 patients, and they restricted enrollment to people with a 10% to 90% pretest likelihood of disease. And the primary endpoint is summarized on the right side of the screen. The UK NICE guidelines recommended coronary angiography in 28% of patients, whereas CMR and SPECT guided strategies recommended about 7.5% and 7% of patients to go on to the cath lab. A secondary endpoint was the outcomes, and these differences in outcomes are not statistically significant. CMR, SPECT, and NICE guidelines all have essentially similar annualized rates, 1.6% for the NICE guidelines, 2% for CMR and SPECT, not significantly different. So sending fewer people to cath lab didn't cause trouble there. Next study I'd like to talk about is the PROMISE study. The objective of PROMISE was to compare health outcomes in patients who presented with new symptoms suggestive of CAD that required further evaluation. And they basically compared 2 strategies. An initial strategy starting with anatomical testing, CCTA, versus a functional testing strategy. And that for PROMISE included stress ECG, SPECT, MPI, or stress echo. Did not actually include CMR, but it's fundamentally a study of anatomy versus functional testing. And the primary hypothesis was that the clinical outcomes in patients assigned to anatomical testing, or CCTA, would be superior to those in patients assigned to functional testing. Great question. This, I thought, was the study that might change cardiology dramatically. And if you look at the New England Journal typical style of showing these kinds of small differences in Kaplan-Meier curves, or in this case, event rate curves, at the full scale, you can't see any difference between the outcome of anatomical and functional testing. Even on the blow-up view, it's not statistically significant. There's a slight deviation, not statistically significant, p.75. So big study, 10,000 patients, and anatomic no better than functional. There were some other interesting things in the PROMISE study. CT recommended 50% more people to go to the cath lab, ended up doubling the number of revascularizations, and so, but without changing outcomes in any measurable way with 10,000 patients. It's also interesting if you look at their radiation exposure, because most of these CT studies or guideline statements say CCTA is about 3 to 5 millisieverts. In PROMISE, the median dose was 10 millisieverts, the mean dose 12 millisieverts. There's a long discussion about radiation dose, probably because it's a little funny. It actually had when done by strategy, because so many stress tests were stress echo or stress ECG, the dose of radiation in that arm was lower than the anatomic. Interesting, but it's certainly not as low as we think CCTA can be done. Let's go to the ischemia trial, another big New England Journal of Medicine study. These are the comparisons of conservative therapy versus invasive strategies. And again, any way you look at these curves, these cumulative incidence curves show overlap and crossing. These are not statistically significantly different for one strategy versus the other. If you break down death from any cause, they're virtually superimposed. Myocardial infarction, slightly different rates at different times, but not statistically significantly different. Let's switch to some really high quality registry data. So Raymond Kwong has done a phenomenal job of organizing and analyzing data in the SCMR sponsored SPINS registry. One objective of this study was to investigate the prognostic value of stress CMR and downstream costs from subsequent cardiac testing in a retrospective multi-center study in the United States. This included data from 13 centers. There was successful follow-up in 2,294 patients. That's 97.7% follow-up, pretty good for a retrospective study from so many sites. Median follow-up of 5.5 years. Big enough study that there were 255 deaths overall. If you look at the primary endpoint, was non-fatal MI or cardiovascular death, 153 primary events. Secondary endpoints, 374, all pretty reasonable outcomes to be looking at. If you look at the primary outcome on the left side of this slide, the sort of purplish blue incidence rate, it represents what happens with an abnormal stress test, stress CMR, defined as both ischemia plus late gadolinium enhancement. Compare that with the blue curve at the bottom. What a normal for both stress perfusion and LGE has a very good prognosis over 8 years. And a combination of either ischemia or LGE positive somewhere in the middle. And if you look at the secondary outcomes, very similar pattern, but the error bars shrink down. And it really is dramatic how much difference there is between normal and abnormal studies. High quality data. The annualized event rates can be displayed in different ways. If we look at the primary outcome in blue, you can see that the rates of normal studies or event rates in an annual rate are very low, 0.6 to 0.9%. We've always been told, at least in my training, that less than 1% is very good. For sake of time, I'm going to skip the rest of that slide. And there's one statement in the guidelines that caught my attention, and they talked about the warranty for a negative stress test being 1 year, warranty for a CCTA, negative CCTA being 2 years. Not sure where that came from, but I was intrigued when I was preparing for this talk. Here's the SPINS data. At 1 year, 0.7% event rate. At 2 years, 0.6% event rate. At 3 years, 0.6%. At 4 years, 0.3%. Oh, maybe we're wearing out a little bit at 5 years at 1.4%. I think the warranty period for CMR looks better than 1 year. If you look at revascularization, another way to measure, and this could pick up false negative studies, 1% at 90 days, 30% or 3% at 1 year, 1%, 1%, 1%, 1%. CMR does not seem to miss a whole lot of important disease. Let's go down to the next really big study, MR Informed. Mike Naggles and colleagues put together really a remarkable study, the CMR equivalent of the FAME studies. And this was an unblinded, international, multi-center, prospective clinical effectiveness trial comparing management of CAD guided by invasive FFR and optimal medical therapy versus management of CAD guided by stress perfusion, CMR plus optimal medical therapy. And that OMT is a big difference between some of the CT studies that get commented on, like Scott Hart. Optimal medical therapy protects people pretty darn well, and I think that helps in these outcomes. Primary endpoint was MACE, death, MI, or repeat revascularization. It was truly a randomized study. Main results here. Stress CMR on the left side, FFR on the right side. The number of abnormal FFRs in this study was 60.8% and only 40.5% for CMR. And the first thing you would think of, oh my gosh, is CMR not sensitive enough? Cath labs are generally the gold standard. And not surprisingly on those results, there's more revascularization than by the FFR strategy than the CMR strategy. That was statistically significant difference. This p-value is looking at the distributions, not being so different. In any case, one could be worried there's a problem here. And yet, there isn't. You look at the outcome study, again, New England Journal style. At the top here in blue and orange, you virtually can't see the orange because they're so well superimposed. You look at the zoom view, no statistically significant difference. The curves cross several times over the course of a year. So the outcome of management by CMR is comparable or equivalent to the management of patients with CAD going through the cath lab, getting FFR. Last, I saw one reference that really caught my attention. I don't know how he pronounces his last name. I'm guessing it's Nuti, but I apologize if that's not correct. But he does, and his group does really high quality meta-analysis work. And they had a figure in one of his recent analysis in 2018 that I found quite intriguing. And basically they're categorizing people by pre-test probability of disease. That's sort of the x-axis in these plots. But the color scale is determined once you've done your tests, what's your post-test probability of disease. And so the bigger a range or bar of orange would say that your post-test, or your ability to rule in CAD, rises above 85%. And the green bars would say your ability to rule out CAD drops below 15%. So the bottom line is those are sort of good endpoints to look at. And if you focus in on the stress ECG data, which is only on the left side here, he concludes, or they conclude, stress ECG has very limited diagnostic power to rule in or rule out CAD when defined by intracoronary invasive coronary angiography. It's only in this range, very high risk and very low risk, that the statistics support good diagnostic power for stress ECG. And it hasn't been tested against FFR. If you look at CCTA, their conclusion is that CCTA can rule in or rule out invasive defined coronary artery disease, cath lab-based coronary disease. But when FFR is considered on the right side of this graph, it's not as good. It can rule out disease, the green bar, but it doesn't do an adequate job in ruling in disease. And we'll see how much bigger the orange bar is for PET and CMR in the next graph. So PET and CMR have moderate diagnostic power when your definition is invasively defined as coronary stenosis. But when you talk about functionally FFR defined, CMR and PET are both better than CCTA. So all that data comes down to a whole series of recommendations. And I'm going to have trouble reading these recommendations unless I can figure out a way to hide your windows. That works. So anyways, I'll go through these quickly, trying to finish up. Level 1 or a class 1 recommendation for using stress perfusion CMR in patients for intermediate risk with acute chest pain and no known CAD who are eligible for cardiac testing. That's a pretty broad recommendation. 2A recommendation for intermediate risk patients with acute chest pain and no known CAD with an inconclusive CCTA. Again, that's pretty reasonable. Another 2A recommendation for intermediate risk patients with acute chest pain and known CAD who have new onset or worsening symptoms. Stress perfusion CMR is on that list. Another 2A recommendation for high-risk patients with acute chest pain who are troponin positive in whom obstructive CAD has been excluded by CCTA or ICA. CMR or echocardiography can be effective in establishing an alternative diagnosis. I used to love those at Suburban Hospital. They thought it was amazing how often we found an answer in those patients. 3 more class 1 recommendations in patients with acute chest pain where there's limited clinical concern of aortic dissection or where there is concern about aortic dissection and CT is contraindicated or not available, and CMR is reasonable. I think that's a good recommendation. In patients with acute chest pain and myocardial injury who have non-obstructive coronary arteries on anatomic testing, in other words, troponin positive, cath comes back negative, Minoka, CMR, that's the choice. Another class 1, in patients with acute chest pain with suspected acute myocarditis, CMR, you all know, is useful here. 2A recommendation, in patients presenting with acute chest pain with known or suspected valvular heart disease. CMR is reasonable if there's a problem with the TTE or the TEE. 2 more class 1 recommendations for intermediate to high risk patients with stable chest pain and no known CAD. Stress imaging in general is approved, CMR included. Another class 1 for patients with obstructive CAD who have stable chest pain despite optimal guideline dictated medical therapy or directed medical therapy. 3 more 2A recommendations for patients with obstructive CAD who have stable chest pain symptoms undergoing stress PET MPI or stress CMR. The addition of MBFR, in other words, quantification, is useful to improve diagnosis accuracy and enhance risk stratification. First time quantification of CMRs in any kind of guideline to my knowledge. Another 2A, for patients with known extensive non-obstructive CAD with stable chest pain symptoms, stress imaging is reasonable. And then the last one, I think, ANOCA, basically, for patients with persistent stable chest pain and non-obstructive CAD, stress CMR with the addition of quantification is reasonable to improve diagnosis and estimate risk. That is my whirlwind tour of 13 new recommendations from the AHA-ACC guidelines. CMR has a big role in the management of chest pain. Thank you very much.
Hi, I'm Balaji Tamarapu, staff at Indiana University Medical Center. And it is a great honor and privilege to be invited to be among these moderators who are one of the giants in the field. And I would like to introduce to you Dr. Michael Salerno, who's the Section Chief of Cardiovascular Imaging, Professor of Cardiovascular Medicine and Radiology at Stanford University. And he will be telling us about stress CMR and how it improves patient care in a multi-modality environment.
All right, thank you very much for the introduction. Are you guys able to see my slides? And can you hear me? Good, okay. So I'm going to talk about how stress CMR improves patient care in a multi-modality environment. And this builds on a lot of what Andrew talked about in the last talk. And again, it's really an honor to be here and be included with this panel and excellent speakers. Here are my disclosures. So overview, what I want to talk about, Andrew just very nicely went through what's in the 2021 guidelines, but it's important to remember where we were back in 2012. I'd also like to talk about CMR in the context of other techniques for evaluating chest pain. Then I'm going to talk about acute chest pain and talk about some of the class 1 recommendations and the unique role in MINOCA and suspected myocarditis. And then more briefly touch on chronic chest pain, specifically focusing on quantitative perfusion and recommendations for CMR and ANOCA. So without going through the whole 13 that Andrew just pointed out, here's a quick overview of the recommendations, numerous class 1 indications for both acute chest pain and stable chest pain. Again, wanted to specifically point out the utility in known CAD prior CABG, suspected MINOCA or myopericarditis, and then ANOCA, which I'll discuss further. So where were we in 2012? It's really the incredible work of the people that Andrew mentioned at the beginning of his talk, that we have the data to be where we are now. But in 2012, pharmacologic stress testing with CMR was thought to be useful in patients who had intermediate or pretest probability of obstructive ischemic heart disease, only in the cases of an uninterpretable EKG in people who are able to exercise, or in patients that were not able to exercise regardless of the EKG. And those are both just 2A recommendations. In fact, only EKG, stress echo, nuclear imaging had class 1 recommendations. So this is what the main chart looked like in the stable ischemic heart disease guideline. So when we're talking about a multimodality approach and thinking about different imaging tests, it's important to think about the strengths and limitations of the different tests. CTA has a high negative predictive value. It can also diagnose non-obstructive disease, which can potentially change therapy. It may be combined with FFRCT and intermediate lesions, which can improve the positive predictive value. The limitations are the radiation dose, iodinated contrast, and downstream costs related to CAF and revascularization, as Dr. Rai pointed out. Stress echo can be combined with exercise, which is a strength, no radiation. It can assess function and valves, as well as inducible wall motion abnormalities. But multiple studies have suggested that, and meta-analytic data has suggested that it's less sensitive than other techniques such as PET and CMR. When we talk about nuclear imaging, at least PET can be combined with exercise. In terms of diagnostic accuracy, SPECT can be combined with exercise. In terms of diagnostic accuracy, PET has a higher diagnostic accuracy than SPECT, and you can quantify perfusion with PET. But the limitations, again, are radiation, which is significantly higher, about 12 millisieverts for PET versus about 3 or 4 millisieverts for, for SPECT as compared to PET. And the cost is higher than that of an MR, and there's issues with availability of PET. And as in this group, we all know that stress CMR has a high diagnostic accuracy. It provides a comprehensive assessment of function, ischemia, and scar, no radiation, And we can quantify perfusion, which is pointed out as some new important things in the guidelines. And that's really going to be something that I think we're going to be doing clinically in the next couple of years. Some of the limitations in the acute setting, it's less available than some other techniques. Some patients can have claustrophobia and some challenges with devices, but really providing very comprehensive information. So multimodality in imaging and chest pain, I think the guidelines actually fit quite well with the idea that one size does not fit all, and we really need to think about what's right for our individual patients. So there's a diagnostic meta-analysis a few years ago, essentially showing when you use FFR as the gold standard, that the different imaging techniques don't all have the same performance. CMR, PET, and CT have a higher negative likelihood ratio than SPECT and echo. And CMR and PET have a higher positive likelihood than SPECT, echo, and CT. And as Andrew nicely pointed out, this figure from the ESC guidelines, while stress CMR, PET, and coronary CTA are all good at ruling out significant coronary artery disease, stress MR and PET are better at ruling in functionally significant disease. Again, when we think about tests at lower risk, there may be some arguments for using an anatomic test, particularly when we don't know if the patient has any coronary disease to establish the presence of coronary disease. This can also be done with a calcium score at lower radiation and no dye. And then as we move to more likelihood of positive tests, we really have advantages for ischemia testing. And this is a figure I'm not going to belabor here, although to point out, as Andrew did, that in asymptomatic patients, we shouldn't be testing. In low risk, in the majority of these patients, we don't need to test. And really, it's the intermediate risk patients and higher risk patients where there's the most benefit. All right, so first starting intermediate risk patients with no known coronary artery disease. And there's equivalent level 1 recommendations for anatomic testing versus stress testing. And although the stress testing is broad here, CMR is included specifically in this recommendation. So here, let's just illustrate a case where I think CMR may be useful. So this is a 70-year-old female with a history of angina and also new onset heart failure and just a borderline flat troponin elevation. She has significant risk factors, including diabetes, hypertension, hyperlipidemia. And of note, given that she has diabetes, she already ought to be on a statin, something that we wouldn't necessarily figure out. We don't necessarily need a CT to figure out that she should be on a statin. And she was referred for a CMR to evaluate for ischemia viability. And so here's her cine imaging. We can see that she's got markedly reduced systolic function. Here's her stress perfusion imaging. We can very nicely see a perfusion defect in the inferior wall and the anterior wall, septum, and inferior wall. And then at the apex, we see anterior wall, inferior wall, and a little bit of the apical lateral wall. LGE imaging shows no evidence of prior infarction. Again, so if we had a CT, we'd know about their coronary disease or in this case, but we wouldn't really know about viability. We also wouldn't know about whether or not they have a non-ischemic cause. And so in this case, we also know that having unrecognized MI is a negative prognostic factor, which this patient doesn't have. And their cardiac catheterization shows high-grade lesion in the right coronary artery, a subtotal occlusion of the mid-LAD, as well as a moderate disease in the OM. So here MR provides information about, as we all know, function, viability, and ischemia. How about patients with prior coronary artery bypass? There's sort of two different techniques that are recommended here, either ischemia testing or CTA to look for graft stenosis. And again, you can do a very nice job with CT looking at grafts. Here we can nicely visualize the course of a right coronary graft, an OM graft, and the lima to LAD. And in this case, with a very nice image quality, we're able to see nicely see the anastomosis of the lima to LAD and visualize the vein grafts. The limitations of this approach is that we don't know anything about what's downstream of these grafts, so we don't know anything about whether or not there's viability. And it's very hard to know about the native coronary disease, which progression of the native coronary disease can also be something that is causing the patient's symptoms. So here's a case of a acute chest pain, a 67-year-old with a prior bypass. We can very clearly see that there's evidence of some edema from a subacute infarct here, as well as late gadolinium enhancement, probably with some degree of intramyocardial hemorrhage. However, when we look at the stress imaging, we can also see that there's significant edema, ischemia in the LAD territory, suggesting that this patient needs further evaluation of their lima, and they actually had disease in their lima. So really, MR is really accurately letting us get function, ischemia, and scar, edema, and microvascular obstruction all in one study. And then, as mentioned by Andrew, 2 specific recommendations about MINOCA, as well as myocarditis, class 1 recommendations for cardiac MRI. So a couple of cases to motivate here. Here's a 16-year-old athlete who has medical history of factor V Leiden. He had left-sided chest pain associated with shortness of breath while he was running. He had a mild troponin elevation. He was actually referred to the CT lab by pediatric cardiology to look for anomalous coronaries as well as obstructive coronary disease, albeit the anomalous coronaries could probably also be evaluated by MR. So his coronary CTA showed a normal course for his coronary arteries. His coronary CTA images didn't demonstrate any plaque or obstruction, and he was referred for CMR for further evaluation of this elevated troponin. And so lo and behold, on his CMR, he has a wall motion abnormality here. These are post-contrast in it. You can see it's already starting to take up some contrast here in the anterolateral wall. And when we look at his T1 maps, we can see that there's evidence of elevated T1, evidence of elevated T2, and late gadolinium enhancement. In this case, likely thought to be potentially an embolic infarct. And when we look back at his CTA, you may be able to argue that, all right, maybe this vessel has a cutoff in the distal part. But again, something where we really got much more information about what was going on in this patient after defining that he didn't have obstructive coronary disease. We see a case like this every couple of years, a 46-year-old male, acute chest pain and a clean calf. And they ordered a cardiac MRI. Cardiac MRI showed evidence of elevated T2 showing edema, a perfusion defect, evidence of LGE with an intramyocardial hemorrhage. And at the time of cath, there was a diagonal branch, which could be barely visualized, which was occluded. How about moving towards a case of myocarditis? This is a 27-year-old with chest pain and suspected myocarditis. He underwent a CMR. His LV function is noted here is sort of globally mildly reduced in the 40s. His native T1 demonstrates increased T1 in the lateral wall here. Post-contrast shows areas of reduced T1 consistent with gadolinium accumulation. His T2 images show myocardial edema in the lateral wall, and the ECV images we can see focal areas of increased ECV. His LGE images in this case show an area of myocarditis. So very clearly in this case, defining that this patient's acute presentation is most likely myocarditis. How about stable chest pain and intermediate to high risk? Both anatomic testing as well as stress testing are given a class 1 indication here, with MRI included in this class 1 indication. Of note, there's a 2A recommendation recommending PET, possibly in preference to SPECT. And I think this is an area where we have some mounting data and where we need to continue to generate data to potentially suggest that maybe MR should be included here as well. In chronic chest pain, what's potentially an advantage? One is that CMR has improved spatial resolution, as pointed out by the studies that Andrew described. CMR outperforms SPECT in looking at 3-vessel disease, primarily due to this ability to actually look at transmural differences in perfusion. And again, as Andrew mentioned, just to say quite quickly, the MR Inform study is really one of the only studies which basically takes a non-invasive test and compares it to invasive FFR in a study that was looking at outcomes. And really, a reduction in revascularizations, but no difference in outcomes, showing that CMR can be used not only for diagnosing coronary artery disease in this group, but also guiding therapy and avoiding invasive studies. How about stable chest pain with known CAD? Again, stress MR is included in this class 1 recommendation for diagnosing myocardial ischemia. So the kind of last topic that I really want to talk about is quantification of myocardial perfusion. And so there's actually two 2A recommendations that are included in the guidelines. And really, this is something unique to PET and MRI, at least in the likelihood of doing this in a clinical standpoint. So for patients with obstructive CAD who have stable chest pain symptoms undergoing stress MPI or stress MRI, the addition of myocardial blood flow is useful to improve diagnostic accuracy and enhance risk stratification. And really nice work from Andrew or Dr. Rye's group in this, demonstrating for fully automated quantitative perfusion, good sensitivity and specificity, as well as a stepwise changes in myocardial perfusion between the areas that were ischemic, remote areas in CAD patients, patients that didn't have CAD, and healthy controls. Also, nice work from Peter Kelman and colleagues on their fully automated quantitative perfusion pipeline. In this study, comparing it to invasive hemodynamics, the top case shows a normal flow reserve and stress flow. In this case, there's no evidence of microvascular disease, and the flow reserve, there was no abnormal FFR. In a patient with microvascular dysfunction, there's sort of globally and subendocardially reduced flow. In this case, this patient's right coronary artery had an index of myocardial resistance of 58, which would be consistent with microvascular disease. And here's a case of multi-vessel coronary artery disease. In this study, they also looked at whether or not global stress perfusion could potentially separate normal flows from those with microvascular disease and those with three vessel disease. While PET is very good at ruling out, in normal flow reserve by PET is very good at ruling out either MVD or three vessel disease, a positive PET actually doesn't have a great specificity for differentiating between MVD and three vessel disease, an area that still requires some more study. And how about ANOCA? So for patients with persistent stable chest pain and non-obstructive CAD, stress CMR with measurement of myocardial flow reserve is reasonable to improve the diagnosis of coronary microvascular dysfunction. And so here's a case of a 57-year-old female with chest pain who underwent coronary angiography. She had no significant coronary artery disease. She was enrolled in one of our studies looking at ANOCA, and her stress images. Again, you can see a little bit of a subendocardial reduction in flow, but globally, when we look at her quantitative perfusion, her stress flow is low and her MPR is low. And in this study, we found that about 2/3 of the people going to the cath lab, we were able to show reductions in the flow reserve, consistent with the high prevalence of microvascular disease among those without obstructive coronary artery disease, specifically in this case for women and patients with diabetes. This has been followed up also with invasive hemodynamics, essentially showing a good performance for detecting abnormal index of myocardial resistance, which is the invasive gold standard for defining microvascular disease. So to summarize, I think it's important to think about the strengths and weaknesses of our different tests. And in this context, CMR has a lot to offer. In the context of multimodality imaging, it's really important to take a patient-centered approach and really think about what information we need and which test is going to be the best at providing that information. We should be happy with the progress that has been made since the last guidelines, now with CMR having a number of class 1 indications in both acute and chronic chest pain, as well as some unique indications for the evaluation of myocarditis and MINOCA, which are new to this set of guidelines. And finally, I think with the direction that the field is moving in with a lot of recent data, I think the guidelines have already started looking at the future to the fact that assessing myocardial blood flow in patients with either known coronary artery disease or suspected ANOCA, these now have class 2A recommendations in the guidelines. So thank you very much for your attention and sharing some of my thoughts about how CMR provides value in a multimodality approach. Thank you.
Well, thank you very much, Michael. This is Matthias Friedrich. I'm a professor of medicine with the Departments of Medicine and Diagnostic Radiology at the McGill University in Montreal. I want to say a thank you for both of you, Andrew and Michael, for beautiful overview of what has been new. I think the guidelines have been a huge move forward, also globally, because it kind of echoes the guidelines that have been published before in Europe. And overall, the key points are that it has been more acknowledged now that the risk of coronary artery disease in patients with chest pain is typically lower than we previously thought. So we do not have to throw testing at as many as we did before. And as both of you mentioned, especially the fact that testing is not recommended in low and very high risk patients, that is what we also see in the ESC guidelines. So I think that is certainly a very, very good move for our healthcare systems. But of course, we're talking here about cardiac MR, and I think the other very important step was that rightfully CMR has moved into the first row of imaging modalities for patients with chest pain, following the overwhelming evidence that has been presented over the last year. So the first question I have basically is to you, Andrew. I know you have been involved in some of the important work in making CMR, say, one of the key technologies here. How do the data and the overall level of evidence for CMR compare with that for SPECT that has been around for so long? And we all heard for many years from nuclear cardiologists, hey, we have 30,000 patients with data on prognosis. So CMR has not been around that long. And of course, it's a pretty North American perspective. So looking at it from a European point of view, nuclear is anyways much stronger in North America than anywhere else. So, but how does the evidence actually compare, Andrew?
That's a great question, Matthias. The evidence for SPECT is deep, but the evidence for SPECT is also older. So most of the SPECT literature compared SPECT versus angiography. There were sort of the early days of doing those kinds of studies. Some of the controls that we now build into those studies, like avoiding too high a risk population or too low a risk population, didn't necessarily get incorporated in. So I think the quality of the cath-based validation is different. And when you look now at the SPECT literature, there are recent studies like CT studies or MR studies that also included nuclear, and nuclear doesn't perform as well in those studies as it did in the studies where it was just going against cath itself. So anyway, so I think there's broad problems there. There are some studies, but not that many, that compared SPECT to FFR, invasive FFR. And the stress echo literature is probably even weaker in some ways. That there's, I don't know of any stress echo study that's compared it with invasive FFR. So in many respects, the last 10 years of MR data, 15 years, has put us in a rich situation that really high quality studies have been performed comparing CMR, quantitative PET, quantitative invasive FFR, the outcomes. So we're lucky. We're at a lucky stage.
Thank you very much. So, Michael, you talked about the use of CMR in a kind of a multi-modality environment, and you talked about the challenges. And although CMR is, if it's available, obviously the better choice, not just because of the diagnostic performance itself, but also because of the comprehensive nature of CMR. You can do pretty much anything in that scan, not just rule out or rule in, but you can also identify the actual diagnosis and provide prognostic markers and all that. So of course, the question is, what can we do to make it more available? So you mentioned the devices in the acute settings, but we know that pacemakers and even defibrillators do not really pose a big problem anymore. But of course, the acute setting, and especially, of course, the length of the scan and the experience you need to run the scan and then to read it. So from your point of view, what would be the next steps to make it as available as in some countries like UK and other European countries?
Yeah, Matthias, I think these are very good points. I think many of us have been frustrated with the relatively slow growth for CMR in the US. I think the couple of key things are, one, making the exam easier, much more push button and shorter. So forgoing rest imaging and really utilizing some of the real-time approaches and rapid approaches for like gadolinium enhancement imaging, we can make this shorter. So that will basically reduce the cost, and then we really have to sell the value of the technique and overcome the fact that a lot of practices have a SPECT camera immediately at their disposal. And then finally, the last thing is we still need to address some of the discrepancies in reimbursement and make sure that CMR is being reimbursed for the amount of time that it takes to perform relative to other techniques.
Thank you very much. So Balaji and Vic, any additional comments to that? What could be the next important move to provide the best care for these patients using CMR?
Go ahead, Balaji.
I really think that the time for the 30-minute stress CMR exam, because one of the reasons I think nuclear has become more popular is also because of these stress-only protocols for especially patients who are having active chest pain symptoms. So I actually think that introduction, or at least more centers doing these very short, abbreviated, very focused studies with just the stress perfusion imaging and using that as a gatekeeper, I think will be very useful, at least from my standpoint. When I am on the consultation service and the inpatient service, that really is, I think, the crux of the issue, at least in my mind. And the second part of it is that everyone, does think of PET, especially because of myocardial blood flow measurements, and also the fact that if you have abnormal stress MBF, you don't even need to have a myocardial perfusion reserve, and that data has been shown. But I don't see why we cannot be using all of the fully quantitative measures as tools to really build up why CMR should be on the same level or perhaps a little bit higher than PET perfusion, for example. And then, of course, the time. PET takes about 2 hours.
Yeah, no, thank you very much. You brought up quantitative perfusion, and there is actually a question in the chat or in the Q&A. So if others have questions, please post it there. Even if we don't have the time to answer them, we will do that then later offline. So the question says, is there a more rigorous appraisal of quantitative perfusion CMR required before we can be more specifically advocating it in guidelines? So Andrew, maybe I know you are involved in some of the efforts on validating the automated quantification of blood flow, or not blood flow, blood flow as defined by perfusion with MR. So what do you think?
Yeah, I think it's an excellent question. The wealth of quantitative perfusion validation studies in the past 4 or 5 years is really high. And so there's suddenly a lot of data to look at. The interesting thing is, I don't know that there's any, at least FDA-approved quantitative perfusion methodology. And generally speaking, FDA approval is needed for making these recommendations, at least for medications. But in the case of medications, if it's approved for another indication, it can make it into guidelines, even though it wasn't approved for that. So I don't know on the regulatory standpoint if the guidelines are a little ahead of where they should be, but there certainly is a lot of validation studies that say its diagnostic accuracy is excellent, it compares well against PET, and it's got good prognostic significance, and it's helpful in small vessel disease. So it's coming if the guidelines are a little ahead, but it's really close.
Yeah.
One other thing of note on the guidelines, right, is that people have looked at both subendocardial ischemia and microvascular disease for many years. People have looked at myocardial perfusion reserve index in microvascular disease, as well as people have measured global flow reserve with phase contrast. So I think it's probably acknowledging that there's, mounting evidence that depending on how you quantify it, that this is potentially useful, and not something that is just only in the future when the fully quantitative stuff is FDA approved.
Oh, I agree. The point of microvascular function was also a very strong one in the guidelines, especially in women. So the entities of INOCA, to a lesser extent MINOCA, but they require us to have a closer look at also the small vessels, and the epicaudal coronary artery status does not necessarily help there. But this brings me to another point, which is about the value, because we talk about cost, we talk about complexity and scanners and reimbursement, but Vic, you have been around and not only in the MR world, but also echo. So you had really the view over the last decade. So what is your take on that for the future? How we should best apply these techniques if we have them all available, and what's the role of the value in that context?
Yes, so the value equation is the cost of the study per information derived. That is, how much additional information do we achieve for the cost of the test? And there have been many good cost effectiveness studies, including one by Raymond Kwong and the SPINS trial recently, as well as by Jörg Schwitter in Europe, who compared studies across countries in Europe as well as in the US. And we'll put that reference later on the SCMR website, because I think that's an important study to note. But Raymond, and I'll note that Andrew trained Raymond, so Andrew gets another extra point for that. But Raymond, in a study of diabetics, looked at the value of unrecognized myocardial infarction in this group. And now he has expanded that finding to the SPINS trial. And there is important value in detecting unsuspected coronary disease or unsuspected infarction in especially the diabetic population, and it also has value in the patients with general screening for chest pain. And so I feel that CMR provides even more value, because it again, it's a no radiation test, so the risk, especially to women who absorb more radiation than men because of more fat and tissue in the chest. As well as women tend to have more microvascular dysfunction, and therefore this can be detected with CMR, and it's not something that's well detected with SPECT. You really have to go to PET for that quantitation, and it also provides a broader and more comprehensive test in terms of tissue characterization. So Michael showed some really nice studies of how T1 and T2 provided value, not just in myocarditis, but also in unsuspected infarction. So Matthias, I think as a value equation, CMR really hits it out of the park with a single study. And its cost is really much more cost effective than the nuclear studies. So and even stress echo actually at different institutions. So
yeah. Thank you very much, Vic. I think you said it very nicely. So before I hand it back over to Ryan, two things. One is the recording of the session will be available tomorrow on the CMR website. So for those of you who know people who missed that, just promote it so people can have a look again. And then I also want to use the opportunity to throw a huge shout out to Chiara Bucciarelli-Ducci. She's in the audience, I know, for her great work with the campaign and with the publication of this. I think this has been a very important and necessary and overdue positive step for CMR and cardiovascular imaging in this setting. Thank you very much, everybody, and back to Ryan.
Thanks so much, Matthias. With that, we must conclude today's webinar. You will soon receive an email from the SCMR with links to the evaluation survey for this webinar. To register for any of our upcoming webinars or meetings, or to view recordings of previous webinars, please visit www.scmr.org. Thank you for your participation in today's webinar. We hope to see you here again soon. This concludes today's program. Thank you. You may now disconnect.